A hypotensive patient arrives in shock. The reflex order gave him a fluid bolus. But there is a trap. In modern critical care units, not all shock needs fluids because in some patients, fluid can actually worsen the shock. Fluid therapy works only in preload responsive states. If the patient is already on the flat part of the Frank-Starling's curve, additional fluid will not increase stroke volume. Actually will increase venous congestion and worsen organ perfusion. This can lead to venous hypertension, impaired renal filtration, interstitial edema in the lungs and the gut. In other words, too much fluid converts distributive shock into a congestive shock. Many trials have reshaped fluid thinking in ICUs. The FEAST trial published in NEJM in 2011 showed that fluid boluses increase mortality compared with no bolus in certain shock states. The clinical ICU NIC would be many septic patients become fluid unresponsive after the first 2 liters. Continuing fluid beyond this often leads to pulmonary edema, abdominal compartment syndrome, and renal venous congestion. This is why modern sepsis care emphasizes on early vasopressors rather than repeated fluid boluses. So before giving the fluid, check the bedside question: is the patient fluid responsive? Use the bedside test like passive leg raising and other things. If stroke volume or pulse pressure does not increase, stop fluids and start pressors at this point of time. This simple maneuver prevents liters of fluid getting into the patient's body. So in shock management, remember, fluids treat hypovolemia, not hypotension.